Hi, my name is Shellen Lee, and today I will be discussing orthopedic procedures, specifically the hip protocol. The hip exam is considered to be one of the top 5 radiographic procedures where the staff at UNC facilities are most often making errors, either from positioning, patient safety, or image quality malfunctions. This learning module will explain how to thoroughly and successfully complete a hip radiographic exam in order to avoid these types of errors. The HIP protocol varies among different healthcare facilities. I've had the opportunity to work at UNC Carolina Point 2 Ortho, UNC Imaging Center, and UNC Ambulatory Care Center to complete my orthopedics rotation. Each clinical site has their own protocol to abide by, but the standard hip protocol consists of an AP pelvis, AP hip, and AP oblique hip projections if the patient has no suspected fractures. If the patient has a fracture, a cross-table lateral projection will be performed. There are two types of cross-table lateral projections, including the Danielius-Miller method and the Clemens-Nakayama modification. Here are some basic information for the projections included in a hip protocol. For the AP pelvis, you're going to use a 44-inch source-to-image receptor distance. It's going to be on a 17 by 14-inch IR in crosswise position. For the AP hip, you're also going to use a 44-inch SAD. According to Merrill's, you're supposed to use about a 10 by 12-inch IR in lengthwise position, but in some of the clinics that I work at, such as CP2 Ortho and UNC Imaging Center, they prefer to include a lot more of the femur and up to the pelvic iliac crest. So 14 by 17-inch IR in lengthwise position will be used in some other places. There's also an AP oblique hip or frog leg projection at 44-inch SAD. Again, according to Merrill's, you should be using about a 10 by 12-inch IR, but some healthcare facilities prefer to have more of the femur included, and so they use a 14 by 17-inch IR in lengthwise position. For the cross-table lateral projection, you'll be using about a 40-inch SAD, which you will have to measure yourself, and a 10 by 12-inch IR in crosswise position. For the AP pelvis radiograph, the patient is going to be lying supine on the table, and the central ray is going to be perpendicular and locked to the center of the table grid. You're going to want to move the tube in longitudinal direction until the central ray is aligned with the center of the IR. This is demonstrated on the image on the very far left. You want to place the top of the IR to about 1 to 1.5 inches above the iliac crest. Make sure that there's no rotation of the pelvis. This is going to prevent foreshortening of the femoral necks. And you can do this by medially rotating the feet and lower limbs about 15 to 20 degrees, and you can see this position shown on the image showing the feet. Unless the patient is a trauma patient or has an injury present or can have suspected fractures, you can perform this. If they do, then you do not want to force them in any type of position or rotate their leg, especially. Some patients can hold their feet in this position, but others may need some positioning aids such as sponges, Velcro, or sandbags. The AP pelvis radiograph is going to be taken on suspended respiration, and you also want to make sure to shield the abdomen, breast, and parts of the femur. Use the appropriate marker to mark whether it is the left or right side of the pelvis, and you want to collimate to 14 by 17 inches to the IR. When you're evaluating the AP pelvis image, you want to make sure that the image includes the iliac crest to the upper third of the femora. You also want to make sure that there's no foreshortening of the femoral necks, so you want to see a small amount of the lesser trochanters and a greater trochanter seen in profile. The picture on the right demonstrates an incorrect AP pelvis because you can see a good amount of the lesser trochanters and the femoral necks have been foreshortened. This is because the patient did not properly medially rotate their feet and lower leg. The picture on the right demonstrates the correct positioning because you can barely see any of the lesser trochanter and the femoral neck is not foreshortened. The ASIS and the greater trochanters should be equal distance from the edge of the image. The iliac crest should be equal distant from the top of the IR. The sacrum and coccyx should be aligned with the pubic symphysis, and the following structures should be symmetrical, and they include the obturator foramina, the ilia ala, the SI joints, and the hips. For the AP hip radiograph, the patient is going to be in supine position with no rotation of the pelvis. That means whichever hip you are imaging, that side of the body, the lower leg, and foot must be immediately rotated 15 to 20 degrees, as long as the patient is non-trauma. The central ray is going to be locked to the center of the grid, and it's going to be perpendicular and entering the femoral neck. And you can find the femoral neck using the hip localizing technique. Make sure to collimate to the IR, whether that be 10 by 12 inch IR or 14 by 17 inch IR, and you want to just collimate side to side if you're using a 14 by 17 inch IR. You want to shield other parts of the femur and the sides of the pelvis, and you can use an AEC center cell with a KVP of approximately 70 to 75. You want to take the exposure on suspended respiration and, of course, mark the right side of the hip, or the correct side of the hip, which may be the right side. When you're evaluating an AP hip radiograph, you want to make sure that all of the appropriate anatomy is seen to avoid repeat. You want to make sure you see the femoral head, the femoral neck, and greater trochanter. You also want to see the upper third of the femur, the acetabulum, which includes the ischium, the pubis, and the ilium. You should also be able to see the femoral neck that is not foreshortened. You want to see the greater trochanter and profile. And if there is an orthopedic appliance, whether that would be a hip replacement, screws, or pins, you should be able to see the entire device, and you want to make sure to not clip it off. When the patient can't completely abduct the thigh due to arthritis and not due to trauma, you can use an AP oblique frog leg hip. Or if the patient cannot abduct the leg 45 degrees, rotate the patient's pelvis slightly towards the affected hip to obtain a similar image or the same image. But for the AP oblique frog leg hip radiograph, the patient is going to be in supine position, and the central ray is going to be locked to the midline of the grid, and it's going to be perpendicular. You also want to make sure that the IR and central ray are aligned, and the patient should flex their affected hip and knee and abduct the thigh about 45 degrees. And remember, this part is done right before the exposure is taken, so that the patient will be holding this position for the shortest amount of time possible. You want to also locate the femoral neck and move the patient until the central ray is entering through the femoral neck. You want to collimate to the IR, whether that would be 10 by 12 inches lengthwise, and cock the tube to get it in the right position. Or if you're using a 14 by 17 inch IR, you want to collimate side to side. You want to shield the abdomen and chest and other part of the femur. You want to use AEC's center cell selection with approximately 70 to 75 kVp, and you want to take the exposure on suspended respiration. Reasons for repeat of the AP oblique frog leg hip radiograph would be that sometimes the anatomy that should be seen may not be shown, such as the femoral head, the neck and greater trochanter, along with the lesser trochanter, but the lesser trochanter is seen on the medial side of the femur. And as you can see on the image on the left, there is some hardware in the femur, and the collimation is very tight. So you want to make sure that the collimation is more open and includes the entire hardware in the femur. For the cross-table lateral projection, also known as the Delius-Miller projection, it's performed when the patient has a suspected hip fracture on a particular hip, which could be the right or the left. In the picture shown below, this patient has a suspected right hip fracture, so the affected leg is extended and the unaffected leg is flexed. A 10 by 12 inch IR with a built-in grid or a grid placed in front of the IR is going to be in lengthwise position placed vertically, and you can have either the patient hold it in place, or it could be put in a or placed in a IR holder. You want to measure for about 40 inches of source to image receptor distance, and the patient is going to be supine on the table, and include the posterior portion of the hip on the image, you need to elevate the pelvis or lower the IR below the patient's hip. The central ray is going to be perpendicular to the IR and horizontal. The tube is going to be placed on the unaffected side, and the unaffected leg, as I mentioned before, is going to be flexed, and the foot will be placed on a vertical sponge. As you can see, the sponge in the picture is white color. The IR is going to be placed in the crease of the iliac crest, and it's going to be angled so that it's parallel with the long axis of the femoral neck. The central ray is going to enter the top of the thigh, and it's going to be perpendicular to the femoral neck. You want to collimate to about 10 by 12 inches or less, and be sure to properly mark the correct side of the hip. But make sure to not put it in the anatomy. This can be kind of difficult. You want to follow the technique chart and select tabletop setting, and make sure to shield the abdomen and chest, and you want to take the exposure on suspended respiration. Also, it's very important to keep the grid perfectly vertical, or this can result in grid cutoff. So when you're evaluating the cross-table lateral hip projection, there could be some reasons for repeat. You want to be able to see the acetabulum to beyond the lesser trochanter. You also want to see the ischial tuberosity, but even you want to consider the density, and you may need to use a compensating filter. If there isn't a compensating filter, then you might want to take one exposure for the femoral head and the acetabulum, and another for the proximal femur. You will have to keep the grid perfectly vertical, as I mentioned previously, because if not, it can result in grid cutoff. And of course, you do not want to place the marker in the anatomy. And this can be kind of hard because you can't directly see the shape of the shadow on the cassette when you're positioning, so you have to be sure to really know where you put your marker. And of course, you want to make sure that the posterior portion of the hip is included on the image. When the patient has bilateral hip fracture, this is when the Clemens-Nakayama modification would come into play. So far, I have never seen at the healthcare facilities that I've worked at perform a Clemens-Nakayama modification, but it's pretty much the same as a regular cross-table lateral, except the patient is going to be supine and both of the legs are going to be extended. You're going to use a 10 by 12 inch IR in lengthwise position held vertically and measure out a 40-inch SID. The central ray is going to be angled about 15 degrees towards the floor, and the patient's legs are going to be fully extended, both of them, and you want to tilt the back of the IR about 15 degrees, and the IR is going to be placed at the iliac crest and angled to be parallel with the femoral neck closest to the IR. The patient will need to hold the IR in position or use an IR holder. So the central ray is going to be centered to the IR, and you're going to collimate to about 10 by 12 inches or less, and of course include the marker, but don't have it in the anatomy. Shield the chest and the abdomen if it's not going to secure the anatomy of interest, and use the technique chart for exposure factors about 80 kVp using AEC. And you should see the acetabulum, the femoral head, neck, and trochanters.
Here are some miscellaneous information that can be relevant for hip procedures at the various UNC healthcare facilities. For example, at UNC Hospital, there are inpatients who come in stretchers. It is much easier and comfortable for the patient to stay in the stretcher for the cross-table lateral, rather than having them transferred over the hard radiographic table. Thus, at UNC Hospital, a lot of the time, the stretchers are angled in a certain way against the wall bucky that positions the femoral neck parallel to it. You also want to look out for older patients who might have osteoporosis, because fractures in the femoral neck and head are common. Metal hardware from open reduction internal fixation and total hip replacements are common and must be entirely included on the radiographic image. There's also a separate exam called the Judet method that specifically looks for fractures in the acetabulum and any deformities in SI joints. So the Judet method is essentially AP oblique projections. So the patient is going to be supine in RPO and LPO positions with a 45-degree angled sponge under one side of the patient for support. Both RPO and LPO projections are performed with a perpendicular central ray entering the affected side. SID is going to be 44 inches. You want to center over the elevated side for the internal oblique position of the affected hip, and you want to center over the side that's down for the external oblique position for affected hip. Thank you for tuning in onto this learning module.